psychologist and assistant professor at the University of Texas Medical Branch in Galveston, and is part of the Department of Psychiatry and Behavioral Sciences there at UTMB. She received her PhD from the University of Texas at Austin, where she studied school psychology and integrated pediatric healthcare. Her doctoral training and fellowship at Dell Medical Center in Austin and Texas Children's Hospital in Houston allowed to further her expertise in trauma-informed pediatric psychology and consultation. Dr. Gushanis' work at UTMB currently revolves around providing trauma-informed services through Texas Child Mental Health Care Consortium, which is we are a part of. And she helps youth, families, and communities affected by significant stressful events, disaster, and suicide. Dr. Gushanis is passionate about improving equity and access to culturally sensitive, preventative mental health care and sees her roles as an educator, clinician, and researcher as essential components to that mission. Dr. Gushanis provides clinical services to Texas schools through the Texas Child Health Access Through Telemedicine, or our TCHAT initiative, which is part of the Texas Child Mental Health Care Consortium. And she also is does research investigation for the Texas Youth Depression, Suicide, and Trauma Research Networks, which is also part of that Texas Child Mental Health Care Consortium. So she's really involved in the work that we're doing to positively impact the mental health care of children here in Texas. She also serves as the Early Career Division Chair of the Texas Psychological Association and volunteers on the board of Exploration Green, a local conservation project in the Clear Lake area. So I am going to turn this over, the screen over to Dr. Gushanis. Let's see if we can get your slides up there, ma'am.
Thank you. Let me try that again. I need to get you guys a shorter bio. That was quite the novel. Thank you for the introduction. I will make sure that we have a shorter one for next time. Let's see. Okay, are we good again? Can you see?
We are good to go.
Okay, well, thank you guys for sticking with Laura through all of that. I appreciate the introduction. Like she said, I am a licensed psychologist trained in school and pediatric psychology, which is a long story for another time. But my role in the past in here at UTMB is really focused on child traumatic stress. And I happen to be also trained in traumatic grief and loss. So I think that this is a really fitting topic that is very much in line with my personal and professional interests. So I'm excited to be here. Thank you all for inviting me back. So just a couple objectives for this in case you haven't seen them yet. My goal is to help you all recognize the most common and most problematic reactions to stressful events for kids and their families. This includes the patients themselves, their parents, and oftentimes siblings or other family members who are present, and then ourselves and our colleagues. I think that that's a really often forgotten component of this. I hope that by the end of this, you'll be able to identify the 3 phases of trauma-informed pediatrics associated with a very commonly used preventative health model in pediatric psychology. It's going to seem very familiar to most of you in the medical field. It's just been kind of specified for pediatric trauma. So we'll talk a little bit more about that in the different phases that kind of help with formulating a treatment plan or a response to intervention for our patients who have been exposed to trauma. And then finally, hopefully you'll be able to create a plan and know of some key things that you can do almost immediately to help intervene with kids and families who might be at risk for PTSD or who were exposed to a traumatic event, and hopefully will be well-versed in a preventative model. by the end of this. My goals is to get you through these 5 points in the next like 40 minutes or so. I'd like to leave us some time at the end for questions. But I don't know how CPN feels about this, but I am more than happy to take breaks and ask questions or answer questions along the way too. So if that's necessary, please put them in the chat, raise your hand. And if I don't see you, like comment in the chat. I can see the chat easier than I can see all of your boxes. So I saw a thumbs up from Laura, so I think that's okay to say. So my goal is to walk through the prevalence and some important criteria and some of this basic symptomology of traumatic stress responses in kids and their families. I'm going to introduce to you the 4 R's of trauma-informed care that SAMHSA and HRSA put out. If you haven't already read through that or aren't familiar with it, it's a really handy way of thinking about this concept. And then what I'd like to do is introduce to you the phased model of trauma-informed pediatric preventative care, which was developed at CHOP, Children's Hospital of Philadelphia, in partnership with some of the researchers in pediatric trauma. They have a really great resource I'll share with you later about all of this. And we're going to discuss some strategies. I'm going to give you some examples of intervention at each of these 3 phases. So depending on what part of pediatric care you play a role in, you should have an idea of how you can approach this issue for each kind of point in care for pediatrics. And then I will share with you resources and recommendations for going the extra mile and giving yourself some more education on this topic if you're interested. So the National Child Traumatic Stress Network, or NCTSN, is kind of the go-to for synthesizing research and resources on child traumatic stress. And their definition of trauma-informed healthcare is medical care in which all parties involved assess, recognize, and respond to the effects of traumatic stress on children, caregivers, and healthcare providers. And I think this is a really important definition to keep in mind for all of us because, oops, sorry, I advanced on accident, I think, because I think it points to the kind of importance of assessment, which is the only way sometimes we become aware of these events in children's lives, but also the ability to recognize these symptoms, recognize the impacts of these experiences on your patients without necessarily asking them, although we should all be doing universal screening. And then how do we respond to this? So when it says all parties involved, it's not just on us as the providers, it's on our system as a whole, it's on our, the front desk staff, it's on our referral system. So we have to make sure that everybody is being mindful of this. And that's really what trauma-informed care is about, is a systemic approach to caring for these patients. So SAMHSA recommends establishing a trauma-informed approach, which they differentiate from trauma-specific services. So we're not talking about a specific intervention with this 4R approach. We're talking about kind of a mindset or a model of thinking about the impacts of trauma on the population. So they're intended to be more of a broad stance. They address high incidence, high risk populations. And the idea is that we can reduce these significant health and social outcomes that we know are associated with trauma if we can take this approach. I'm seeing there's some issues with seeing the slides. Is anybody else having that problem? Can someone unmute and say?
I can see it with no problem.
Okay, thank you. Hopefully.
Are others more quick?
Yeah.
Sure.
Are others?
I can see them fine.
Okay,
I can see them fine, Laura.
Okay. Maybe Miss Evans is having a technical difficulty on her Teams. Sorry.
Possibly.
Yeah, sometimes if you switch views, you can. Okay. So, we're going to talk through these. I'm not going to spend too much time on this. I just want you to be aware of it and know that it's out there. It's a really helpful guide. The 4 R's are to realize, which stands for realizing the widespread impact of trauma and its risk factors. So this is basically be aware of the prevalence, which is essentially, especially in Texas these days, pretty much everyone that shows up to your office by the time they turn 18 will have been exposed to a traumatic event. It's highly unlikely these days that kids aren't being exposed to trauma, whether or not it is traumatizing for them. That's something that is very subjective to the patient, and part of the next R, which is recognizing the signs and symptoms of trauma in your clients. Not only your patients, but also their families, their siblings, your own staff members, depending on the context of the traumatic situation. And the next R is responding. So knowing how to respond effectively with a fully integrated model of understanding trauma and supporting policies in your workplace that prevent re-traumatization for patients where that's necessary, and that promote protective factors and prevention efforts. So the idea here is that we want to be universally screening patients and connecting patients very early, just like any other concern that you'd see come through your care. Early intervention is always best in trauma-informed care. So if it's necessary, having a response already planned before the patient gets to your office is part of a trauma-informed approach. And then last is resisting re-traumatization. So actively shaping your environment, your physical environment, your policies, the people who you have working in your environment, making sure everyone's trained and understanding the sensitivity of these experiences and how they impact our patients and their families, and even communities as a whole, and understanding the nuances of that so that we can do our best to prevent re-traumatizing these patients through standard medical care. And I could talk to you guys for hours about that. So data from a recent meta-analysis, I see there's some issues here, so we'll make sure that those get cleared up when we send these out. But data from a recent large meta-analysis found that up to 80% of pediatric patients and their families experience some level of traumatic stress reaction after being exposed to a life-threatening illness, having a serious or life-threatening injury, or painful medical procedure. So we can talk generally about childhood trauma, which includes things like abuse and neglect and mass violence. But more specifically, I'm going to talk about pediatric or medical trauma today, where it's in the traumatic situation is induced by a medical event. And I think that that's really relevant for most of us as pediatric providers, but also to be informed about the nuance of specific medical trauma, because it does present a couple of extra stressful components when a kid has to come back to a doctor or be in a medical environment to get treated after experiencing a medical trauma. In general, though, we know that at least half of the patients that you're going to come in contact with will have at least one significant trauma exposure by the time they leave your offices or graduate care into adult care. Sorry, if you're here, please mute yourself if you haven't already. Thank you. The likelihood of developing post-traumatic stress symptoms is actually quite low. The prevalence of trauma exposure is very high, but the most common reaction is actually resilience in children, especially. So PTSD, traumatic stress, traumatic loss, these things can show up across the lifespan. So even if a child is exposed to a trauma when they're 7, they might not develop symptoms until they're 17, 27, 42. It can present at any time throughout the lifespan, depending on the nature of the traumatic event that they experienced. So while I'm talking to you about exposure and current PTSD symptoms, this is also important to think about in the lifespan approach to care, and knowing that patients who have these exposures, even if they aren't currently experiencing symptoms, they are at risk for developing PTSD, depression, anxiety. Those things go up later on in life. So you as a pediatric provider are really the front lines, because they're going to show up to you before they're going to show up to me as a psychologist. And they're going to talk to you about their problems usually a lot faster than they're going to talk to anybody else. Most people go to their pediatrician for just about everything. Even academic concerns will show themselves in your office before they'll show up at school or with me. So you are really important in the process of identifying and preventing increased risk later in life. Just for review, to kind of expand your headspace on this, if you're not thinking about this as often as I am, I think it can be really helpful to understand the different areas, the sources that often present traumatic events in children. There's a lot out there that can cause these experiences for kids. And sometimes it can just be helpful in terms of recognizing the prevalence of just how many things can sometimes contribute to this experience. So we know external circumstances and events are very common. Things like community violence, school shootings, natural disasters. These are all things that we unfortunately deal with a lot in Texas, especially in my region down in the Gulf Coast. Unfortunately, terrorism, hate crimes, things like that are on the rise these days. Unintentional injuries, things that have happened, like falling on the playground or a car accident, things like that. Or immigrant or refugee traumas, which are a population that we often forget about, even if it's not the child who's the direct migrant or a refugee. There are caregiver-specific related traumas that occur in kids. This is specific to children. It involves caregivers, whether that's parents, legal guardians, whoever is supposed to be responsible for them. It can include things like domestic violence, direct abuse of like maltreatment of the child, but can also be things like watching a parent with substance use or with their own severe mental health issues. A caregiver dying. We unfortunately saw this a lot in COVID. I worked with a lot of kids who lost a parent during that time, and just separation in general. So sometimes just things like parental incarceration or deportation, those things can be traumatic for a kid. Trauma is defined as a life-threatening situation and an event that the child feels has threatened their life or someone that they loved. So it is subjective, but it is also clear in many situations that a kid could take that perspective of this could be a threat to my life when something happens to my parents. And then last is medical trauma, and that is basically anything that is medical or health related. So these accidental injuries, again, scary or painful medical procedures, chronic illnesses that require invasive medical treatments, new high-risk diagnoses, especially if there's a fatality risk. So there's a lot of different components of medical care that can be really difficult for kids to process as well. So what predicts the severity of these traumatic stress responses? So we know that it's subjective, right? We know that kids don't always produce traumatic stress symptoms, like clinical symptoms of PTSD after experiencing something like this. But when they do, how do we know that it's going to be severe enough to need intervention? So what predicts this level of severity? And really our social context is what informs how we, different types of people, different identities experience the world around us, and how we understand and navigate these systems and structures that support us. So especially kids who have very little control over their lives, where they grow up, who's around them, what school they go to, their community that they live in. Their social context is extremely important for understanding their symptom development. So the context of their society, where they live, the beliefs of the people around them, their specific community, access to resources, their schools, their own families, and then their own beliefs and understandings, how they've internalized what's happened to them, what is happening around them. Traumatic stress, and all of its sequelae, like other internal experiences, they occur within the individual, but they exist within this bigger context. So as providers, we have to be thinking kind of ecologically like this, to think about not only helping the child, but also focusing all of these systems that support them and potentially prevent these things from being high risk. So your power as a pediatrician or as a pediatric provider is helping to build resilience and helping to build these promote these protective factors for these kids, regardless of their individual identity or community, recognizing what's happening in their communities or in their own experience, and then responding to that in an effective way, and with sensitivity, which I think is something that most pediatricians tend to have. I'm using the word protective factors and risk factors and vulnerability factors you'll hear me talk about. This is kind of an easy formula maybe to help understand the balance of predicting severity from traumatic events, or the likelihood of developing post-traumatic stress. And what we have to think about is there's always causal risk factors. So these are the things that are aspects of the event that occurred. So the level of perceived threat to their life is a causal risk factor. Whether or not the event included violence, which is a risk factor for increased stress, whether it include death that the child then is bereaving. So if there's grief involved, and then the chronicity of the traumatic exposure. So how often did this happen to them? Was it reoccurring? Those are things, causal risk factors, that can increase stress reactions, that increase the severity. Vulnerability factors are things that might be present before these things occur. So vulnerability to stress that was present before this traumatic event occurred. And this could also include any other secondary adversities that occur because of the trauma. So the trauma itself is the causal risk factor, and then a kid might be extra vulnerable to developing stress reactions if, for example, it was their parent who died, and now their entire daily life has changed because they're in a single parent home, or maybe grandparents moved in to help, or auntie moved in to help, and now there's a different adult providing care, or multiple adults providing care, or none at all, and now they're with a completely different person than they were before. Maybe they had to switch schools because they had to go move in with mom or dad or auntie across town, and they're in a different school district. So we're thinking about these things that are inherent to the child or to the circumstances that are not because of the trauma, but they're kind of secondarily related to what happened in the circumstances that they're now living in. And these things, they may weigh on the child. These risk factors, these vulnerability factors weigh down. The protective factors are the things that are already in place that can be buffers to the stress that they might experience. So this is stuff like social support systems, early intervention, the relationship health between the parent and the child, living in a safe community. So these are things that protect the child from developing higher risk outcomes later in life. we see trouble when these things are imbalanced. So when there is more vulnerability and causal risk, then there are protective factors. And that's where the evidence tells us that pediatricians and pediatric providers can come in very helpful, because you're so front lines with these kids, really helping to identify what protective factors are in place, where are the weaknesses in this child's ecology, like the kind of circles of care that we talked about before, and where can we intervene to help increase the protective factors, really enhance the positive adjustment of this child so that we can prevent greater severity moving forward in life. And Ann Kazak, who's like a icon in the pediatric trauma field of psychology, she has done a lot of research on this, and very simply says that the strongest predictor of recovery from a traumatic event in childhood is safe, stable, and nurturing environments. And this isn't talking specifically about the home. So I invite you as pediatric providers to consider your role in being a safe, stable, and nurturing environment for your patients. So knowing the prevalence of trauma, knowing that at least 50% of your kids will have experienced a significant traumatic event, upwards of 80% who have any medical complications, and 20% of kids who come to you with a severe injury or illness have current symptoms of post-traumatic stress. Knowing that prevalency, kind of taking this universal precautions approach to trauma, which is like, just assume that everybody's got a bloodborne pathogen and prepare yourself, protect yourself. Same idea here. Just assume that every patient that walks in has probably been exposed to something in their lives that could be potentially traumatic, and be that safe, stable, nurturing person in their world. Even if it's only once a year that they see you, be the person that they can rely on, that they know, that they feel safe talking to, and that they know is going to act when they see an issue that needs to be taken care of. So I'm going to move us into recognizing the signs and symptoms of trauma. If this is repetitive for people, I invite you to think about the kind of unique qualities that tend to show up in your patients when they're experiencing these types of symptoms. So we should all be familiar and objectively know the criteria for post-traumatic stress disorder. If you're not familiar, there's 5 kind of core categories of symptoms that show up in different ways for different people, but they're actually the same from child to adulthood. So PTSD can look very different for different people, but they will always have these core kind of criteria, these core symptom clusters. So what I'm going to do is I'm going to dig into each of these just briefly a little bit more to give you some examples of what you might hear from your patients or their families about what this is looking like in their lives. So sometimes they're not going to come to you and say, hey, we went through this really traumatic thing and now I'm seeing this. Sometimes you're just going to hear these complaints. And if you haven't done an assessment for trauma, then you might not know that they've experienced something like that. And so this can sometimes be a helpful tool for thinking about the etiology of some of these complaints. So the first criteria is obviously exposure to a life-threatening event. That is the only criteria for PTSD that is exclusionary. The rest of these people can display any kind of level or spectrum of these symptoms, and they can have subclinical stress reactions without having a full-blown PTSD diagnosis that still predicts some risk in their life. So keeping that in mind, exposure to a life-threatening event is an important criteria for PTSD. Re-experiencing is any kind of intrusive experience that's related to what happened. So repeated thoughts, thinking a lot about what happened, having intrusive images pop into their head or memories. Sometimes these are in the form of nightmares. Sometimes they're in the form of actual flashbacks, which is the specific like re-experiencing almost like you've been like teleported back to the experience, not just a memory. It can be kind of dissociative in nature as well. Intrusive implies that they're unwanted and that they typically cause distress. So these are some of the things that you'll hear from patients. Every time I close my eyes, I see this happening again, or they report having specific flashbacks or nightmares. In children, the nightmares don't actually have to be related to what happened. It could just be a sudden increase in having nightmares, could be a sign of post-traumatic stress. Feeling that the event's happening all over again, crying when they hear reminders or see or smell reminders of what happened, having distressing dreams about similar or related situations. So these are some examples of how re-experiencing can show up. The next is avoidance, which is a strong tendency to avoid people, places, situations, words, objects, smells, sounds, anything that reminds them of what happened, and an intentional or unintentional urge to avoid those things. So I don't want to think about it. I don't want to be around it. I want to do anything that reminds me about what happened. And sometimes these are subconscious for kids. But it can produce a very small life. It can really shrink their ability to like get out and do things and to connect socially with their peers, to pay attention in school if they're very avoidant all the time. So examples of avoidance is I try not to think about it. I don't like to talk about it. Parents will tell you they don't want to talk about it. They shut down every time we bring it up. Or they'll say things like, I'm not going back there, or parents will complain that like they refuse to do certain things because it reminds them or it's related to what happened. So there's some very common complaints. Negative cognition and mood. What this means is not like they're just, grouchy all the time. What it means is negative changes. So the shift to what appears to be like a negative filter on their mindset. So this can include their selves. So like perceiving themselves negatively or their self in danger. Safety is a big theme for kids with PTSD, or just PTS symptoms, not even a full-blown disorder. So fearful of their own safety, not trusting themselves or other people, seeing the world as unsafe in general. It could look like excessively blaming other people or themselves for what happened. It can lead to feelings of being like very unworthy. A lot of guilt shows up in traumatic stress reactions. We've all heard of survivor's guilt, but even that can even apply to situations where there wasn't a death involved. So it can be just surviving this traumatic experience in general can lead to feelings of guilt. It can also look like numbness or detachment from what happened, this kind of negative or numb shift, or negative beliefs about the people around them after what happened, the changes that they've experienced. So you can see on the left here some examples of what that might look like. They don't trust people. They feel like they're never going to be able to get back to normal. They feel a lot of guilt, like they could have done something to prevent it, or they should have done something different. Caregivers report like a change in personality, or we see this kind of numb, depressed almost presentation of like, I don't care, I don't know, it doesn't matter, what's the point, that kind of stuff. Hyperarousal is the last core criteria of traumatic stress reactions, and this is what it sounds like. You all know the arousal system better than I do. So hypervigilance, that is physiological, but also mentally they present more anxious or on edge. This is often where ADHD gets misdiagnosed. A lot of kids with trauma exposure get misdiagnosed as ADHD. When it's not really an executive functioning difficulty, it's this hypervigilance, hyperarousal as a result of what they experience. There's a lot of overlap. Exaggerated startle responses, jumping really loudly, not liking surprises, being very irritable and on edge just in general, and having trouble sleeping or concentrating. So this is where we see impairments in school and relationships, eating, even relaxing. All these things can be very difficult for a kid who's highly aroused. And then in some situations, dissociative features show up, like the flashbacks fall into that category sometimes, or other things like spacing out a lot. We know there's not a history of epilepsy, so could it be related to something that they've experienced? Things they don't feel, they say things don't feel real, like they're in a fog, or like they're living in a dream. Sometimes they even report these outer body experiences when they're stressed out, or they feel like they're just not themselves anymore. So these are all examples of how these symptoms can present, these complaints that should be followed up on if you're hearing them from your kids or from their parents. I'm going to pause. Any questions about like PTSD specifically?
Dr. Davis did have a question, and his question was, what about repeat traumas or micro traumas without the ability to escape, like in the theoretical CPTSD?
Yeah. I'm not familiar with the word micro trauma. Well, maybe Dr. Davis, I'll have to consult with you after that. But repeated chronic traumas or complex trauma, which is what I think you're referring to as CPTSD, those are essentially just higher risk for patients. So we consider that as one of those causal risk factors. If there is chronic trauma, repeated trauma, or complex trauma, which means lots of different types of trauma that they've experienced over the course of time, that increases risk significantly for negative health and mental health outcomes. It increases lots of secondary risk, which is actually my next slide. So I'm going to move that over here. Let me see. There you go. So Dr. Davis, was there a specific question you had about this? Like, what about these things? If you're still with us. Okay. We'll come back to you later if you're here. Oh, got it. You were just asking. Yeah. So chronic stressors or chronic trauma is one of those causal risk factors. So that can be something that, if anything occurs more than once, it can exacerbate the outcomes related to that. And it puts them at higher risk, not only for developing PTSD, but also for these secondary adversities. So these are listed here for you to look at. We know that trauma impacts the caregivers, the family, right? That ecological context. Even if the trauma only happened to the child, it can impact the people around them significantly. And you know this as pediatricians or pediatric providers as well. Like, it's not always easy to turn that emotional reaction off when you have a patient in front of you who's been traumatized by something. Family conflict and separation happens a lot after childhood traumas, depending on what happened. Sometimes it's just too much stress on the family and it creates conflict or separation. Sometimes there's legal problems involved. I have several patients who in the area have been victims of gun violence or are violent crime, and they're having to deal with court cases and legal issues that they're required to be a part of because of what happened. And that can be really difficult for some families, especially if the legal problem is related to the child themselves. Bereavement and grief adds a whole new dimension of loss and separation. Discrimination, victimization, those are things that can occur because of the traumatic experience, or the trauma can occur because of these things. And then changes in daily routines or lifestyles. Like I said, sometimes that's a secondary factor of going through something traumatic, and that can be extremely disruptive to kids. And it kind of is the antithesis of, we talked about a safe, stable, nurturing environment. When everything has to shift, you're adding on these adjustments on top of the stress of what happened. It can be really tough for some kids. These are all things that we can be thinking about as providers as areas of opportunity to help promote and increase those protective factors. So if we know that the parents are depressed and then the kid goes through this trauma, like we need to be addressing the caregiver health and the child's health, because we know that a depressed parent is not going to be able to necessarily provide this safe, stable, nurturing environment the way that they would if they had an appropriate intervention or if they wanted it, right? So sometimes there are areas for intervention that don't look like direct intervention with the child who's been exposed to trauma, but it does actually impact the health outcomes of the patient that we serve. I'm not going to go through these, but I do want you to be aware of developmentally appropriate reactions to grief. So when a traumatic experience produces a death of someone that child knew or loved, especially, there are expectations and appropriate reactions that you'll see from patients. And this is true of trauma as well, not just grief or traumatic grief, but there is a period of time, this acute period of time, where we expect to see all of these symptoms in some capacity. That would be a normal reaction to a life-threatening situation or the death of someone that you loved. And so we want to consider the developmental appropriateness of their behavior or their complaints. And then we also want to consider the time since the trauma happened, which we'll get to in just a second. So these are here. I'm not going to go through them with you, but I do think grief is something that's not really talked about very much, not in this society or the American culture. And it's also not talked about much medically. So it's something to be aware of and something to read up on a little bit, but know that it can be a component that exacerbates stress for some kids and can exacerbate risk factors that you would be managing in your offices. For the sake of time, I'm going to go through this slide pretty quickly. But one thing that I want to point out for traumatic grief symptoms that shows up often and kind of scares people are reunification fantasies. So when kids, or anyone, adults as well, but when kids talk about like wanting to die so that they can be with grandpa in heaven, or thinking about dying a lot, thinking about what happened and, daydreaming about being with them again, or saying things like, I wish I had died, or I can't wait to see them again. Sometimes that really freaks people out. It freaks parents out, especially, but that is actually a very normal reaction. The problem is when they kind of get stuck thinking about this, and they kind of over-identify with this concept of like being reunited. So it's normal for kids to talk about this after a death, to wish for the separation to not be true, to wish to be with this person again. That doesn't necessarily mean that they're suicidal, but it does mean that you should do a suicide risk assessment or have someone come in and do that for you if you're not trained in that. I'm going to pass this quote up, but it's a really good one. Just talks about the relation of grief to like a stress response system. It's been well studied. Okay, so how do we respond when this stuff shows up? How do we deal with trauma when it happens in our patients' lives? So we have this phased approach. There's the peri-trauma, or the kind of initial moments or situations where the trauma occurred, which involves this objective event that was potentially traumatic, a life-threatening event, and the perception of that event, which is the subjective piece, and that's the piece that predicts PTSD. In this phase, the peri-trauma phase, our goal is to address the experience and to set them up with education about what happened and what to expect, and then to keep that on our radar to follow up on later. There's not a lot to be done in the moment it happens. So if any of you are first responders, you're probably not thinking like, how do I emotionally prepare this child for the long term with this event? Like, you're responding to the emergency at hand, and that's okay. That's what we should be doing at this phase. So peri-trauma, let's skip ahead really quick. are the immediate moments after the event occurs. We're identifying that they've been exposed to a traumatic event. The kid may or may not yet perceive this as a stressful event or even life-threatening event, even if it was. And so our goal is to address emergent needs. Are they safe? Do they have pain? And connect them to sources of support for any other issues that might be going on. We should also be assessing for these vulnerability factors and potential risk factors that says that this kid needs to be followed up with. There is a pediatric preventative health model that addresses child traumatic stress from a public health perspective. It's just another way of thinking about these 3 phases. I like to make sure that we're all thinking about it in this way. There's the universal interventions that everybody gets that's designed to be preventative. And then when someone is identified as at risk or having experienced a trauma, then they move up to this targeted intervention phase 2. Where we're following up a little bit more frequently, we're evaluating their symptoms, we're really specifically looking at these risk factors to identify changes, and then we're referring to tier 3 or clinical treatment when there is risk present or when there are symptoms present. I do have a case example, but I think I've talked to you too much. I'm sorry, guys. This will be available on the slides, and I'm more than happy to be available for contact outside of this presentation if you have a case or want to talk through one. But there is a case example here for those of you who have access to the slides after. So going back to this phased approach, the 3 phases of our roles as pediatric providers, moving past the peri-trauma phase is the acute phase. So this is within 30 days of exposure, and this is where we tend to see normative acute stress reaction. So people present with symptoms like PTSD, but if it's within 30 days, we consider that to be normative. We consider those to be appropriate responses to life-threatening situations. So we don't want to over-pathologize yet. We don't want to get too excited about it. I told you at the beginning that most people's reaction to trauma is actually resilience. But we also do want to be mindful of the risk factors and the potential for this to worsen for patients. So this acute phase, we just want to focus on screening and referral to intervention if that's present. So using brief screeners, using universal screeners in your pediatric visits or with your patients on your units and your clinics can be a really helpful tool here. I have a slide in the deck with recommendations on that and the resources for some commonly used screeners that are very easy to implement and free. We also want to be screening siblings who were involved or who know about what happened. I think siblings get forgotten often, and then caregivers as well for their own post-traumatic stress responses to what happened. Here, preventative education is really important. So helping them understand what you're experiencing is actually normal. We would expect that to be true. But if it goes on past 30 days, or if you start to notice that it's impairing functioning at school or socially, or not wanting to get out of bed, those kinds of things are happening, then after 30 days, we want to start being a little more concerned about that. So you want to prepare patients, you want to talk to them about what's going to happen, say it's normal to have nightmares for a little bit, it's normal for your brain to be confused about what's going on or why this happened to you. Give them materials to read, talk the caregivers through what symptoms are expected and what the red flags are for coming back. And counsel them on the grief reactions too, if there was a death involved. Make sure they know how to support their kids, how to answer questions in an age-appropriate way, how to talk to them about what it means that this person has died. Using the word death is really important for some families. Loss is actually not recommended. And then when there is another risk or vulnerability factor that you're aware of, like a caregiver mental health issue, or the kid's got a learning disability and they're struggling academically already, things that we know are already ongoing risk factors, we can intervene and ensure that we're following up on those a little bit more closely as well in this acute phase. And then do everything you can to strengthen their support systems. Tell parents, get them back to normal routines, get them involved in social activities, really help amp up these protective factors to make sure that we're kind of buffering against the effects of this stress long term. And then finally, sorry, Jake, we're neglecting your case. Finally is the phase 3, not early acute phase. I'm sorry, that's an error. This is the post-traumatic phase. So this is after 30 days and throughout the lifespan of the traumatic event occurring. This is where we need to continue doing intermittent screening. I advocate for pediatricians at my institution to just plug this into well child checks. Every single year, be assessing for the post-traumatic stress symptoms if you know, especially if you know that a child's been through something like this, because PTSD can develop throughout the lifespan. And in fact, it's very frequent that we see symptoms develop later in life after another stressful event or after some other kind of stressor occurs, that these traumatic stress reactions kind of circle back later in life. It's not uncommon. And then, of course, this is kind of the point where it leaves your responsibility as a pediatric health provider, and it's then on someone else to treat when there are clinical symptoms of PTSD present or enough stress reactions that it's causing impairments. Maybe they can't be fully diagnosed, or you don't have access to someone who does that diagnosis for them. But there's enough going on to say this is impairing their functioning. We have to get them referred to an evidence-based provider. So I've listed here a couple of the therapies that patients should be referred to in these situations. That being said, these are often hard to find, although through this Texas Child Mental Health Care Consortium, there are actually several avenues now for getting access to this type of treatment for our patients. So I encourage you to follow up on learning a little bit more about those options through the research programs and TChat. And then referral to social work or any other kind of care manager that you have at your facility to address any of those secondary concerns, legal issues, housing issues, getting them to school, helping them adjust to a new environment, those kinds of things. And then lastly, resisting re-traumatization. Again, I'm not going to spend too much time here, but I do think it's important to note that we are responsible for communicating effectively with our patients and making sure that they know what to expect when they come to see us or when they're, when you're performing an exam, things like that, that we're doing our best to make sure that we are preventing any kind of potentially re-traumatic or re-traumatizing experiences for patients when they're in our office. And if we had more time, I'd elaborate a little bit more on that, but I apologize. So really quick, I'm just going to share some resources with you so you know that they're here to reference later. This is a trauma-specific screening tools. These are specific short screeners, very short questionnaires that you can use in any pediatric setting. These have been validated across different types of healthcare settings. So the acute stress checklist is something we often use in emergency rooms and follow-up trauma clinics. The other three on here, the middle two, child and adolescent trauma screen, and the CPSS, these are specific PTSD screeners, can be very helpful for making referrals if they meet a clinical threshold. And then post-traumatic stress checklist is appropriate for use in older adolescents and adults as well. So you can use that to help screen in parents or older siblings. There's a whole slide full of resources here for you. Some clinical reports from AAP, information on trauma-informed care as a whole, some book recommendations, some podcast recommendations. I've tried to cover all forms of audience and making sure that you have resources for following up here. One that I want to point out, though, is Healthcare Toolbox. This is specifically the pediatric medical trauma website developed by Children's Hospital and the Center for Pediatric Traumatic Stress. So there's a ton of great information, CEUs for medical providers, nurses, screening tools, lots of really good stuff here at healthcaretoolbox.org. And references for those of you like me who want to read up on stuff like this. So we have just a few minutes. I'm available for questions if anybody has them.
Thank you, Dr. Kashanis. That's such an excellent topic, and one we actually want to facilitate again in 2025 because it is such an important topic. And we have thousands of providers in the state of Texas who need this education. So
Agreed.
please, if you want to ask a question, unmute yourself, folks, and please ask. You have an expert here. And no need to be shy.
I have a question. In terms of therapy for young kids like toddlers or even elementary and middle school.
I'm so sorry to interrupt you. I'm having a very difficult time hearing you. Is there any way you can get closer to the microphone?
Yes, I'm trying. What about now?
It's a little bit better. Let's try again.
Okay. In terms of therapy or response for kids, young kids like toddlers, elementary and middle school kids, what do you think about EMDR therapy?
EMDR has some evidence in adults, but there is no evidence in children. So typically the evidence in adult populations is that it's effective when paired with another evidence-based treatment like cognitive behavior therapy. I would guess that that's true for kids as well. So it might be a helpful addition to evidence-based treatment for children, but there isn't enough research yet to say that it's a good recommendation. So we have other treatments that we know are effective that I would recommend first. And what I usually tell patients that ask about EMDR specifically is that for parents, great. If you want to do that and if you feel it's helping you, go for it. It can't hurt. But for kids, it's not the first line of treatment yet.
Thank you so much.
Yeah, you're welcome. Great question. It's a popular topic these days.
Yes,
And
absolutely.
I would say the same about play therapy for anyone who's been asked that question as well. Also not an evidence-based approach. In fact, significantly less evidence for play therapy than for EMDR. So like I tell parents, play therapy isn't going to hurt your kids to go pay somebody to play with them, but it's probably not going to help. It's probably not going to address any specific symptoms of PTSD, other than perhaps providing them some really good coping tools, which a lot of play therapists do teach very well. So it's just something kind of a nuance of what we're treating that we want to pay attention to when we're making those referrals.
Doctor, how young? Oh, I'm muted. Oh, can you hear me?
No, you're good. I can hear you.
How young do you suggest for EMDR? You may have mentioned that and I missed it, but what is the youngest that you feel EMDR is effective or appropriate?
So what I was saying is that I can't speak to its effectiveness at all for any age. There's not enough research out there on it to show that it is an effective recommendation at any age. So there's a lot more research that says it's probably efficacious in adults, but there's not enough yet in kids. So I wouldn't actually make that recommendation personally.
Thank you.
Yeah, absolutely. Any other questions? All right. Well, I'm happy to make myself available. Laura, I don't know if our contact information is here. You can Google me if not. But I'm happy to make myself available for anyone that has questions or needs a consultation.